두 번째 발제자분은 조지 워싱턴 대학의 보건대학원인 윌컨 인스티튜트 스쿨 오브 퍼블릭 헬스의 캐서린 아스널 교수님이십니다. 캐서린 아스널 교수님은 이전에 하버드 보건대학원에서 리서치 어소시에이트로 연구활동을 하시면서 하이 퀄리티 헬스 시스템을 주제로 했던 란셋 글로벌 헬스 커미션의 멤버로 참여를 하셨었고 현재 코비드-19 그 글로벌 프로젝트 그리고 백신 헤지턴시 프로젝트의 PI로 연구를 하고 계십니다. 오늘 캐서린 아스널 교수님께서는 Quality of First Antenatal Care Visit and Management of Risk Factors in Pregnancy, Findings from Ethiopia, India, Kenya, and South Africa라는 주제로 발표를 해주시는데 녹화 동영상으로 보내주셨습니다. 그럼 시작 부탁드립니다.
Hi everyone, my name is Catherine Arsenault. I'm an assistant professor in the Department of Global Health at George Washington University Milken Institute School of Public Health in Washington, D.C. I'm a former colleague of Professor Huayong Li. We both work at the Harvard Chan School of Public Health under the mentorship of Professor Margaret Crook and for the Quest Network. So the presentation that I'm going to give today is about a paper that's been recently published in the journal PLOS Medicine on the quality of first antenatal care visits and the management of risks in pregnancy. This is a study that was conducted simultaneously in Ethiopia, Kenya, India, and South Africa. So we know that a large majority of pregnant women now access skilled ANC at least once during their pregnancy. Globally, it's estimated to be 88%. ANC is important to address prevalent health risk in low and middle income countries and during pregnancy, including things like anemia, malnutrition, infections, chronic illnesses, or depression. And according to WHO, ANC should include 4 key components. It should be used for risk identification, for the prevention and management of pregnancy-related and concurrent diseases, for health education, and for health promotion. So many risks during pregnancy are modifiable, and they can be detected and addressed in pregnancy to improve maternal and neonatal outcomes. The detection and timely referral of these pregnancies is crucial. And previous studies have shown that there are gaps in ANC quality and in the provision of essential clinical actions during pregnancy, including things like monitoring the blood pressure, taking urine and blood tests, and giving women iron and folic acid. But there's currently little evidence on the performance of health systems in detecting and addressing specific health problems during pregnancy. So in this paper, we had several aims. The first was to describe the quality of first ANC visits among 4,068 women that were enrolled in 4 countries. We wanted to investigate whether women with risk factors tend to receive higher quality care, and we wanted to describe the quality of pregnancy risk detection and management of risk during the first visit. And we assessed specifically the quality of detection and management for 7 pregnancy illnesses or risk factors: anemia, undernutrition, obesity, chronic illnesses, depression, prior obstetric complications, and danger signs. By the way, this picture here is a comprehensive health post in one of the sites in Ethiopia. So this study is based on the baseline survey. So it's a cross-sectional analysis of a baseline survey of a longitudinal study on maternal and newborn healthcare quality in 4 countries, which we call the Maternal and Newborn Health E cohort. The E is for electronic because the follow-up is done over the phone. The MNHE cohort was done in 4 countries simultaneously, and in 2 sites in each country, one predominantly urban and one mostly rural site. The women were enrolled in person across 93 health facilities during their first ANC visit. There were no restrictions on gestational age, so women could be coming in at the beginning or towards the end of their pregnancy. The only criteria was for the data collectors and the health providers to determine whether it was truly a first visit that should include the full set of services when women are seen for the first time. Women had to be either 15 or 18 years old, depending on regulations in the countries, and they had to plan to remain in the site throughout their pregnancy. The baseline survey included a women's survey, so a survey with the pregnant woman, physical health measures, and a brief facility observation, observing the facility where women got their first ANC visit, and a review of maternal health cards or records. So in Ethiopia, we included 2 sites. As I said, an urban and a more rural site. The urban site was in the town of Adama, and the rural site was near the town of Adama in Ishewa. Both are fairly close to the capital of Ethiopia. In Kenya, women were enrolled in Kiambu, which is a more urban county near the capital, Nairobi, and half of the women were enrolled in Kitui, a more rural site. In South Africa, we were working with the University of KwaZulu-Natal and recruited women in Umlatuse, which is an urban area, and Nongoma, which is a much more rural site. And finally, in India, we enrolled women in 2 states, Haryana and Rajasthan, and both states included rural and urban women around the district of Sonipat in Haryana and Jodhpur in Rajasthan. So just to keep in mind that these are not nationally representative data, they're essentially, we aim for the data to be representative of the site selected only. In terms of measures, the first thing that we looked at is the quality of the first ANC visit. We included a large set of indicators to assess quality, including whether women got necessary physical examinations, whether they got all the required diagnostic tests, like blood samples, urine sample, ultrasounds, whether they were screened and the provider took their history necessary for high quality antenatal care, whether they received counseling on several things included here on the slide, and whether women received iron and folic acid, calcium supplements, deworming medication, and tetanus vaccination. In Kenya, we also look at the provision of insecticide-treated bed nets. We also assessed a series of antenatal risk factors. The first was anemia. So if women had received a blood test and the result for their hemoglobin level was written in the card, the data collector simply extracted that level to identify whether the woman had anemia. If there were no tests performed, then the data collectors performed their own tests to assess her hemoglobin level. Same thing for hypertension. So we either took the blood pressure result from the card, measured the blood pressure during the enrollment, or asked the woman if she had had a previous diagnosis of hypertension. The same thing was done for diabetes. Women also reported whether they had any other long-standing chronic illnesses. Other risk factors included being younger than 20 or older than 35, having any history of obstetric complications, or a known multiple pregnancy at the first ANC visit. Women reported previous C-sections, stillbirths, premature births, low birth weight, neonatal death, or previous postpartum hemorrhages. And finally, we also looked at nutritional status, including whether they were underweight or obese. This was based either on the BMI or the mid-upper arm circumference measure. So moving on to the results. In terms of the characteristics of the women, we found some interesting things across the 4 countries and the 8 sites. Adolescent women were more that were pregnant, so women under the age of 20 were most commonly found in rural Kenya and rural South Africa, where there was nearly around 20%, 1 in 5 women was very young. There was some interesting variation in health literacy. So in India and in the rural site in South Africa, only about 10 to 16% of women were able to correctly answer 6 very basic health literacy questions. So this might be correlated with low levels of education or younger age, potentially. We also found interesting differences in terms of women who were married or partnered at the time. In Ethiopia and India, almost 100% of women were married or partnered, but only 9 to 14% of women were married in South Africa. Depression rates range from 9% in India to 46% in rural South Africa. This was assessed by the data collectors using the PHQ-9 questionnaire. There was also some interesting variation in whether or not the pregnancy was intended. Up to 92% of women in India said their pregnancy was intended, but only 16 to 18% only in South Africa. The women were enrolled during their first ANC visit, but these women came in at different gestational ages. Kenya was the country where women came late for antenatal care. The majority were in the 2nd trimester, and 26% of women in the rural county in Kitui came in their 3rd trimester already to receive care for the first time. We also found a high prevalence of antenatal risk factor. So here on the left side, you have anemia. Between 11% of women in Ethiopia were anemic to 48% in India. Self-reported history of at least 1 chronic illness ranged from 6% in India to 35% in South Africa. Most of this was HIV. Being underweight was highest in Ethiopia, where 22% of women were underweight, 16% in India, and a much lower prevalence in South Africa and Kenya. So in contrast, obesity, so having a BMI greater or equal to 30, was more common in South Africa and Kenya. Previous C-sections or previous obstetric complications range from 15 to 26%. And so the proportion of women that had at least one of these risk factors ranged from 55% in India to 85% in South Africa. This variable was our main predictor in the following analyses, but we also looked at the count of risk factor. So looking at the proportion of women with no risk factor, only 1 or 2 or more, and in the case of South Africa, 2 or more or 3 or more risk factors. So coming back to our quality of the first ANC visit, we found an interesting gradient across the 8 sites. The median quality or completeness of the visit, which is the proportion of required items completed, ranged from about 43% in Ethiopia, 66% in Kenya, 73% in India, and closer to 80% in South Africa. The items that were least performed were the counseling measures, some of the history screening and history taking and screening. In Ethiopia, there were also a small proportion of women who got certain important treatments and supplements, and some physical examinations that were rarely performed as well. So we conducted some linear regression analyses to assess whether the presence of risk factors was associated with ANC completeness. And we found that it was not strongly associated. Kenya was the only country where having at least one risk factor was associated with a 1.7 percentage point only increase in ANC completeness. In the other countries, it was not statistically significant. We also repeated the analysis looking at the number of risk factors, so having only one, two risk factors, or three or more risk factors, and found the exact same thing. It was only statistically significant in Kenya and with a very small coefficient. We found that other things were associated with better ANC quality. That included being wealthier, so being in the highest wealth quintile in Ethiopia, receiving ANC in a better staffed facility, that increased quality by 11.8 percentage points, having a secondary school education in Kenya, and receiving ANC in a better equipped facility, which increased quality by 4.6 percentage points. And finally, in South Africa, receiving ANC in a higher volume facility actually reduced quality. Volume was defined by the number of antenatal care visits each month in the facility. As a second analysis, we also looked at women that had 7 different common risk factors or concurrent illnesses. And we looked at the proportion of these women that had the risk factor detected during the first ANC visit and had some level of management. So these measures were, of course, not always the best. They're proxy for good quality. But what we found is really striking gaps in the provision, the detection and management of these risk factors. For anemia, most women did receive a blood test during the visit, but in Ethiopia, there was a lower proportion of anemic women that got their iron and folic acid either given or prescribed, only 70%. For women that had chronic illnesses, only between 42 and 68% actually discussed the chronic illness during the visit, and very few were referred for specialized care, which is either being told to go to the hospital or tertiary care for antenatal care, or being told to see an obstetrician or gynecologist. Undernutrition was generally assessed in Kenya, India, and South Africa, but in Ethiopia, which had the highest prevalence of malnutrition, only 14% of women with malnutrition actually had their mid-upper arm circumference measured or their weight and height. In terms of management of undernutrition, which is either giving or telling women to get food supplementation, it was very low, ranging from 0 women in Kenya to 6% in Ethiopia and South Africa. So prior obstetric complications, women who told us, the researchers, that they had had previous neonatal deaths, stillbirths, or preterm birth, very few in Ethiopia, and only about 2/3 in South Africa, India, and Kenya discussed that history with the health provider during the visit. Few were referred or told to see a specialist in tertiary care. Similarly, women with danger signs were not always discussing the danger sign. And finally, I think one of the most striking results is that women that scored positive for depression were actually very unlikely to be screened for depression. And among those who were screened for depression, there were very few, less than 3%, that were actually either prescribed antidepressants or simply referred to a mental health provider or being told that they should receive psychotherapy. So we looked a little further in terms of the content of care for women with risk factors. This here is showing the proportion of women with an ultrasound, depending on whether they have a risk factor or not, and the self-reported time spent with the health provider during ANC. In Ethiopia, we found absolutely no difference in ultrasound in time. In India, women with risk factors were actually less likely to get an ultrasound, and they spent only 21 minutes with the health providers compared to 32 minutes for women with no risk factors. There were no difference in Kenya, and in South Africa, women with risk factors may have spent 6 minutes more with the health provider during the visit, but they were actually less likely to get, they were less likely to get an ultrasound, unfortunately. So what we found is important gaps in ANC quality and little to no evidence that women with risk factors are going to be getting better quality care. We found poor levels of screening for malnutrition, depression, chronic illnesses, and pregnancy danger signs. Women with prior obstetric complications, which are important predictors of future obstetric complications, were not likely to discuss these during their antenatal care visits. We also found that women who initiate ANC late in pregnancy, which further reduces the potential benefit of antenatal care. And the findings in this paper only relate to the first ANC visit. Our future analyses that look at follow-up visits and follow-up data are going to allow us to determine whether follow-up care results in better management of these health problems. In terms of the policy implications, what this points to is the fact that simply increasing the number of ANC visits from only 4 to 8 visits is unlikely to improve health outcomes. What antenatal care requires is a better assessment of pregnant women, better communication of risks, and better referral of pregnant women between primary and secondary levels. The data from this paper can guide regional health managers to start thinking about improvement strategies